Hello dear friends, after yesterday's topic of SIADH, let's move on to the rest of endocrine pathology. So we are going to deal with three topics here: primary polydipsia, diabetes insipidus, hypopituitarism and acromegaly. First of all, please note the page number, that is page number 344 is what we are dealing with. Okay. So let us go to our flashcard intro. It's like I'm an EPG aspirant and we are trying to annotate the first slide and it's trying to have a quick look on the first slide in order to make it easy. It's like let's study together. Okay. First of all, you look at the page number, that is page number 344 of USMLE Step 1 2022 edition. Okay, so we have got lots to do today. We start with this primary polydipsia and diabetes insipidus. This primary polydipsia and diabetes insipidus, it is characterized by the production of large amount of dilute urine with or without a thirst. So what thirst? That is, we have got large amount of dilute urine without thirst. That is the common characteristics between primary polydipsia and diabetes insipidus. Let us just have an intro about what is primary polydipsia. Primary polydipsia means the patient has got some psychiatric illness or the hypothalamic lesions affecting the thirst center. We know that we have got hypothalamic nuclei that control satiety, that control food intake, appetite and thirst. So the food intake, hunger and also water intake, everything is controlled by the lateral hypothalamus, whereas satiety is controlled by the ventromedial hypothalamus. Okay, so it's like our stomach is situated in our ventral part and in the medial side, not on the lateral side. Therefore it is satiety. When this end, that is the ventromedial part is stimulated, we get satiety. Okay, and our hands are located on the lateral part of our body. Therefore when you have got some stimulation to our hands, that is when you have a cupcake in your hand, you are going to eat that. Therefore hunger, food, water, that is thirst and appetite, everything is stimulated by the lateral nucleus of the hypothalamus. So why did we say this? Because of psychiatric illness and hypothalamic lesions affecting the third center, there will be excessive water intake. Whereas when you say diabetes insipidus, what is diabetes insipidus going to do? Diabetes insipidus means there is some problem with the ADH. Either there is decreased ADH release from the sender, problem is from the sender called as central diabetes insipidus, or it is due to ADH resistance. The receptors are resistant to ADH. ADH, even though produced, is not able to act on the receptors. It is called as nephrogenic diabetes insipidus. So in common, both of these are characterized by the production of large amount of dilute urine. Okay, so since it is a dilute urine, specific gravity of urine is less than 1.006. Urine osmolarity, it is also going to be decreased because of dilute urine, less than 300 milliosmol per kilogram. Central diabetes insipidus may be transient if the damage is below the hypothalamic median eminence or in the posterior pituitary. ADH in the hypothalamus can be secreted systemically via the portal capillaries in the median eminence. Let's make that simple. Okay, check this. This thing over here, this blue letter, this one is the if we look here we have got hypothalamic median eminence, and downward we have got a pathway where this hypothalamic median eminence or the hypothalamus secretes a antidiuretic hormone, that is vasopressin and oxytocin, and it is going to go by the pituitary stalk and is by the hypophyseal stalk and finally going to get into the posterior pituitary where it is stored and released when it is necessary. If there is a lesion at this point, this ADH secretion via this pathway is affected, but still the ADH is going to reach the systemic circulation. How? There are many portal capillaries in the median eminence. These portal capillaries are going to release this ADH from the hypothalamic median eminence to the systemic circulation. So we don't get an ADH deficiency and central diabetes insipidus, even though you have got central diabetes insipidus in damage below the hypothalamic median eminence, but it is going to be transient because these portal capillaries are going to do that function. Okay, now let us go into primary polydipsia, central diabetes insipidus and nephrogenic diabetes insipidus. Let's look at it one by one. Before that, yesterday we were talking about syndrome of inappropriate ADH secretion, where there was loads of ADH getting secreted. So ADH is also called as vasopressin. Yes, ADH is also called as vasopressin. Another name is AVP. AVP is arginine vasopressin, that we see a lot in our first aid book again, and they are going to act on medullary collecting duct, aquaporin channels. Which aquaporin they are going to act on? They are going to act on aquaporin 2, and ADH is going to act on the V2 receptors. Okay, there are V1 receptors, V2 receptor. ADH is going to act on the V2 receptors on the serosal surface of renal tubular cells, luminal surface, and it is going to act via which pathway? Second messenger system. It is cyclic GMP. There are two hormones, two important hormones that act via the system. One is nitric oxide, the other one is nitric oxide and also ADH. Both of them are going to act via the cyclic GMP system. Okay. Then primary polydipsia. What is primary polydipsia? Even from this word we know that dipsia means there is excessive water drinking. Excessive water drinking because of some psychiatric illness we told, and also it could be like OCD or hypothalamic lesions affecting the third center. Okay. What about the serum osmolality? We are drinking a lot of water, then our blood is going to get diluted. Therefore, serum osmolality is reduced. What about the ADH level? ADH level, anti-diuretic hormone. Should our body secrete ADH and prevent diuresis in this condition? No, it is decreased or normal because we have got enough or more amount of fluid inside our body. The person is drinking a lot of water. Therefore, we are not going to secrete ADH. Water restriction. If you restrict the water, means if you ask the patient to stop drinking water, or if you prevent the person from drinking water, or if you restrict his fluid intake, we will see that the problem is gone. There will be a significant increase in the urine osmolality. Urine osmolality increases to more than 700 milliosmol per kg. Okay, there is a significant increase in the urine osmolality. Desmopressin administration. What is this desmopressin? Desmopressin is an ADH analog. Desmopressin is an ADH analog. If we give an ADH analog, any problem? Anything is going to happen? Nothing. That is not a part of our pathogenesis. Okay, then what about the treatment? You restrict water. Simply restrict water. It's just a psychogenic problem or a hypothalamic lesion affecting the third center. Therefore, you just need to restrict water. What about central diabetes insipidus? Central diabetes insipidus is because of ADH release. A decreased ADH release is the reason of central diabetes insipidus. How can that happen? It can happen idiopathically. We don't know why ADH is getting released less from in our body. Then it can also be because of brain injury. Who produces ADH? From the hypothalamus. No? So because of brain injury also this can occur, like trauma. Then brain injury can occur due to hypoxia, some tumor, due to some surgery, or infiltrated diseases. Okay, here there is reduced ADH secretion, means no water is getting held back, therefore lots of water getting excreted, and loss of water leads to hypernatremia here. Okay, here what happened? There was excessive water intake in primary polydipsia, therefore there was hyponatremia. In nephrogenic diabetes insipidus also, ADH is not going to act, therefore here also we have got hyponatremia. So that is one difference done. Primary polydipsia hyponatremia, central diabetes insipidus hypernatremia, nephrogenic is hyponatremia. Then idiopathic brain injury trauma, this we read now. And now what about the serum osmolality? If serum osmolality in central diabetes insipidus is going to be high, serum osmolality is going to be high because loss of water is happening, solutes are getting trapped inside our body. Serum osmolality is high only. Then ADH level, now we have got decreased ADH, that is evident. No? So ADH level is low only. Water restriction, if we do this water restriction test, will there be any change? No, the problem is not with increased water consumption, it is due to decreased ADH. So there is no change or a slight increase in the urine osmolality on water restriction. Desmopressin administration, that is going to help now. What was desmopressin? Desmopressin was an ADH analog. Therefore, if you give an ADH analog, we see that the problem is reversed. We are going to have a significant increase in the urine osmolality, more than 50% is going to occur with desmopressin administration. Then, so the treatment is desmopressin or DDABP. This is what I told. This DDABP is, what is DDABP? 1-D-amino, 8-D-arginine vasopressin. So in effect it is arginine vasopressin or vasopressin only. Desmopressin is what we are going to give as a treatment of central diabetes insipidus. Now we go to nephrogenic diabetes insipidus. Here we have got a problem with the receptors, or the ADH is forming but it is not able to act. ADH is, resistance to ADH is the problem in nephrogenic diabetes insipidus. It could be hereditary. Hereditary like ADH receptor mutation could be a reason, or it could be due to some drugs like lithium that we give for bipolar disorder, psychiatric illnesses. Demyelination. This is another drug that causes nephrogenic diabetes insipidus. We saw that in the figure also yesterday. Lithium and demyelination is going to cause nephrogenic diabetes insipidus. Okay, then hypercalcemia and hypokalemia, these metabolic abnormalities can cause nephrogenic diabetes insipidus, to be remembered. Okay, hypercalcemia, hypokalemia are two metabolic abnormalities that lead to nephrogenic diabetes insipidus. Because of this, the person is going to have polyuria, polydipsia like symptoms. Okay, what about serum osmolality? In a nephrogenic diabetes insipidus also, all the things are going to be similar in central diabetes insipidus and in nephrogenic. Both of them are having the similar mechanism of action, because in effect the ADH is not acting. Therefore, serum osmolality is increased in central diabetes insipidus. Here also serum osmolality is increased. What about the ADH level? ADH level is decreased here, but here the ADH is being produced, but it's not being acted on the body. Therefore, ADH levels are normal, or it is increased. Okay. And what about the water restriction test? If we do a water restriction test, will there be any change? No, there is no change, or there might be a slight increase in the urine osmolality in central diabetes insipidus. In nephrogenic, there is also no change or slight increase in the urine osmolality, the same sentence. Okay. What about desmopressin administration? Here the problem was decreased ADH, therefore there is significant increase in the urine osmolality, but here there is a minimal change in the urine osmolality. Why? Because ADH analog, desmopressin is an ADH analog. Even if we give that, if there is a receptor problem, will that be able to compensate for that? No. So what are we going to do as a treatment of this nephrogenic diabetes insipidus? We are going to manage the underlying cause by using a low solute diet. HCT, what is this? Hydrochlorothiazide, amiloride, indomethacin. So manage the underlying cause. Low solute diet. Hydrochlorothiazide is a thiazide diuretic that acts on the distal collecting duct. NaCl, calcium, all these things are reabsorbed. What is its amiloride? Amiloride is a potassium sparing diuretic. Potassium, H+, are getting absorbed and sodium is going out. It is located in the collecting duct. Okay. So let us check on what is happening in thiazide diuretic. Thiazides, when we give the thiazide, it will promote the PCT to absorb a lot of water. It will increase the PCT water reabsorption and block the ability of DCT to form dilute urine. Okay. Therefore, urine osmolality in effect increases. That is why we are giving thiazides in a condition where the antidiuretic hormone is deficient or is not acting. This thiazides increases the water reabsorption from the PCT and also blocks the ability of DCT to form dilute urine, that by increases urine osmolality. What about amiloride? Amiloride is we know that it is a potassium sparing diuretic that acts on the collecting the potassium, and H+ is getting absorbed and sodium is given out. Amiloride is the drug of choice for lithium induced diabetes insipidus. All these are previous questions. Okay. Lithium induced diabetes insipidus means if a patient comes with bipolar disorder and he has suddenly developed polyuria, polydipsia like symptoms. So we suspect diabetes insipidus because of lithium. The drug of choice is going to be this potassium sparing diuretic, amiloride. Okay. Now let us check, are there any questions here? Okay, central diabetes insipidus can be due to this brain injury. So it is actually brain injury. Here in the question we will have a buzzword of absence of postpituitary bright spot on MRI. That is leading to this central diabetes insipidus. Okay, then what else? We have got rapid correction of hyponatremia. We know that in primary polydipsia we have got hyponatremia, central and nephrogenic we have got hypernatremia. If we do this rapid correction of hyponatremia, we are going to have this thing called as central pontine myelinosis. Please, I apologize for my handwriting. Central pontine myelinosis is, or CPM, is what is going to happen. That is called as osmotic demyelination syndrome. If you are rapidly correcting sodium, there will be lot of sodium inside the or outside the cell. There is lots of sodium, so water is going to move out of the cell into the interstitial space, and therefore there will be myelin tissue degeneration. That is called as central pontine myelinosis or osmotic demyelination syndrome. Okay, so that is all from this page. Now we go on to the other page, that is 345. Okay, now we go on to hypopituitarism. There are lots of questions from NEET, AIMS. I have collected it all. So now we go on to hypopituitarism. Hypopituitarism. Under secretion of pituitary hormone, as the name suggests, is hypopituitarism. It is due to a non-secreting pituitary adenoma or craniopharyngioma. If it was a secreting pituitary adenoma, we are not going to have hypopituitarism, no? So it is a non-secreting pituitary adenoma or craniopharyngioma that causes hypopituitarism. Sheehan syndrome, we all know this. After the after the delivery of the baby, if the mother is having severe bleeding and hypotension, so for some time the pituitary is not going to get enough blood, and therefore there will be ischemic infarct of the pituitary following severe postpartum hemorrhage. Therefore it is a pregnancy induced during the pregnancy time there will be a pregnancy induced pituitary growth leading to increased susceptibility to hypoperfusion. Already during the pregnancy time we made them to grow better, and therefore they had lots of requirement for blood, and now suddenly because of this hypotension and postpartum hemorrhage, now there is hypoperfusion and they are susceptible to ischemic infarct. Okay, that ischemic infarct of the pituitary following severe postpartum hemorrhage is called as Sheehan syndrome. Usually presents with failure to lactate, absent menstruation, cold intolerance. Okay, what are the questions that we have here? Which is the recent NEET question. First to fall in Sheehan syndrome. Which is the first to fall in Sheehan syndrome? Is that growth hormone, prolactin, LH, FSH? Which one? The first to fall in Sheehan syndrome is growth hormone. Growth hormone is the first to get fold in Sheehan syndrome. Then it is prolactin, then LH, FSH, and then ACTH. Okay, what do you give for the management of Sheehan syndrome? NEET question, recent NEET question. Management, you are going to give corticosteroids first because we have got adrenal insufficiency here, primary adrenal insufficiency. The patient is going to go into shock. Therefore, first of all, our management is corticosteroids, and then you are going to replace the other pituitary hormones that are deficient. We will see that in the next page. Okay. Then empty cellar syndrome. What is called as empty cellar syndrome? There is nothing in the cellar turcica. That is called as empty cellar syndrome. It is due to the atrophy or compression of the pituitary which lies in the cellar turcica. Often idiopathic, common in whom? Obese females. Obese females, we have got nothing inside the cell. Therefore, empty cellar syndrome is seen in obese females associated with idiopathic intracranial hypertension. It is idiopathic. We don't know why this hypertension is happening inside the cranium. So, idiopathic intracranial hypotension, obese females have got this thing called as empty cellar syndrome. Pituitary apoplexy. It is an emergency sudden hemorrhage of the pituitary gland, often in the presence of an existing pituitary adenoma. Often it has got a pituitary adenoma. Already we have got a pituitary adenoma. Sudden hemorrhage of the pituitary gland is called as pituitary apoplexy. It usually presents with a sudden onset of a severe headache, visual impairment. For example, bitemporal hemianopia, diplopia due to cranial nerve 3 palsy, and features of hypopituitarism. Okay, so the recent NEET question. Pituitary apoplexy. Okay, the reason NEET question is because of this hypopituitarism there will be sudden adrenal insufficiency, so the feature will be shock. What is the presenting feature of the sudden adrenal insufficiency or pituitary apoplexy? The question was something like that. Okay, so what are you going to give for this thing? For this pituitary apoplexy, you are going to give high dose of glucocorticoids. You are going to give high dose of glucocorticoids and you are going to do surgical decompression. Surgical decompression plus resection of the resection can be done in pituitary apoplexy. We can give high dose of glucocorticoids or surgical decompression. Okay. Then other causes of hypopituitarism is brain injury and also radiation. These are other causes of hypopituitarism. How do you treat? You treat by hormone replacement therapy like glucocorticoid, thyroxine, chest steroids, human growth hormone and all. Pituitary had ACTH has secreted glucocorticoids, mineralocorticoids, TSH, thyroxine, FSH, LH, sex steroids, then growth hormone, human growth hormone. Then AIMS. What are the other causes of pituitary apoplexy? Here in first aid we know that pituitary adenoma and underlying pituitary adenoma is one cause of pituitary apoplexy. What are the other causes? Diabetes mellitus, hypertension, our metabolic syndrome people, diabetes mellitus, hypertension, these are other causes. Then sickle cell anemia, a strange cause, no? Sickle cell anemia is one cause of pituitary apoplexy. Sheehan syndrome is another cause, and acute shock and pituitary adenoma. These are all causes of pituitary apoplexy. In AIMS, one option was hypothyroidism. So this is not a cause of pituitary apoplexy. That is another question. Then what? AIMS. Why? Mineralocorticoid is not supplied. If the person is having hypopituitarism, we don't supply mineralocorticoid. Here also, we know that we supplemented glucocorticoid but not mineralocorticoid. Why? Because this mineralocorticoid is not under the pituitary control. Because mineralocorticoid is regulated by the RAS system and not the ACTH. Okay, it is not by the ACTH that regulates this mineralocorticoid. It is by the RAS system that regulates the mineralocorticoids. Okay. Then what other question do we have? We have a recent need question that say most common functioning tumor of pituitary. We know that hypopituitarism is caused by non-functioning tumor of the pituitary, which is the most common functioning tumor of pituitary. It is a prolactin secreting adenoma. Prolactin secreting adenoma is the most common functioning tumor of the pituitary, which is a non-functioning adenomas. They mostly arise from the gonadotrophic cells. It is from the gonadotroph cells that non-functioning adenomas mostly arise from. Most common functioning tumor of pituitary is prolactin secreting adenoma. Non-functioning adenomas arise from the gonadotrophic cells. Then what is this non-functioning adenoma going to cause? Non-functioning adenomas are going to cause hypopituitarism, one thing. Then there will be mass effect. Okay, because of this mass effect, we are going to have bitemporal hemianopia. Bitemporal hemianopia because of compression on the optic chiasma. Then hyperproliferation, hyperprolactinemia can occur initially, and then because of decreased dopamine, it inhibits the lactotroph. Okay, low dopamine inhibits the lactotroph, and then the prolactin is also going to decrease, and finally there will be pan-hypopituitarism. Okay, initially in non-functioning adenoma you are going to have hyperprolactinemia, and then dopamine decreases and inhibits the lactotroph, then pan-hypopituitarism is going to occur. Then pituitary tumors are associated with MEN1, MEN4, Carney complex tumors and McCune-Albright syndrome. Okay. So if in the option, if there is MEN2, that's not the answer, no. In MEN2 it is medullary thyroid cancer and pheochromocytoma. MEN1 it is PAR-PAN-PIT, that is PAR is parathyroid adenoma, pancreas, pituitary. These three are affected in MEN1. In MEN2, medullary thyroid carcinoma and pheochromocytoma. MEN4, Carney complex, McCune-Albright syndrome. MEN1 for these are the syndromes that are getting affected, means associated with the pituitary tumors. Okay, then what else do we have? That's all. Then we go on to acromegaly. Acromegaly is due to excess of growth hormone in adults and not in children. Increase in the growth hormone in children leads to gigantism. Increased growth hormone in adults typically caused by a pituitary adenoma. Will that be functional? Functional. Then growth hormone in children, if it is increased during the growing age, if you have got large amount of growth hormone, there will be increased linear bone growth, no? Therefore there will be gigantism. Okay. Then what are the findings in acromegaly? Large tongue, everything large tongue will be there, deep furrows will be there, frontal bossing, coarsening of the facial features with aging, deep voice, diaphoresis. What is diaphoresis? Excessive sweating, impaired glucose tolerance like diabetes mellitus, no? Impaired glucose tolerance, insulin resistance will be there, hypertension, left ventricular hypertrophy, diastolic heart failure is the most common cause of death. I have seen this as a question somewhere. Diastolic heart failure is the most common cause of death here. Okay, then diagnosis. How do you diagnose this? Increase the serum, insulin like growth factor 1 will be present, and there will also be failure to suppress the serum growth hormone following oral glucose tolerance test. Normally, when you give glucose, what is going to have? We are going to have a suppression in the growth hormone. Growth hormone is going to decrease on giving oral glucose. But if there is failure of growth hormone or the serum growth hormone is not getting suppressed after an oral glucose tolerance test, it means that it is not under control. So that is one way to diagnose. Increase serum IGF-1 and failure to suppress the serum growth hormone following oral glucose tolerance test. Increase in serum IGF-1 is a screening, is like a screening test for acromegaly. If IGF-1 is normal, we can say that it is not acromegaly. But if the serum IGF-1 is increased, we can say that there is a chance of acromegaly. You can, for confirming that, you are going to use this oral glucose tolerance test or the growth hormone suppression test. Then you look at the brain MRI, you are going to see a pituitary mass is seen on the brain MRI. Okay, now we have got two people here. Here you can see that what are the features that you see in this pretty lady. See, we have got frontal bossing, coarse facial features, then deep voice, diaphoresis, everything will be there. Large tongue, deep furrows. Okay. So what are you going to do as a treatment? Treatment, if it is due to typically it goes due to a pituitary adenoma, we know. Therefore, it is due to this pituitary adenoma, you are going to resect it. If not cured, treat with Octreo, right? So let's check it. We are going to have we have lots of growth hormone now. So we need to oppose the growth hormone. What are the three things that we are going to give to oppose the growth hormone? One is a somatostatin analog. Somatostatin analog like octreotide is going to be given. So what does this do? Somatostatin, it is going to decrease the growth hormone and decrease the TSH. So in effect, growth hormone is going to get decreased if you give octreotide, which is a somatostatin analog. Then if we give a growth hormone receptor antagonist, is that going to work? Yes, that is also going to work. So we give pecvisoman, that is a growth hormone receptor antagonist. Then if you are giving a dopamine agonist, that is also going to help to reduce growth hormone. So we give cabergoline, that is a growth hormone agonist. Okay. Then we look at the previous questions. There is something called as Wolfram syndrome associated with diabetes insipidus that we learned previously. That code is DIDMOD. DIDMOD is the code. So diabetes insipidus, diabetes mellitus. So diabetes insipidus has occurred. DIDMOD. DM is diabetes mellitus. Then OA is optic atrophy, and finally you have got D. What is that? Sensory neural deafness. So this is called as Wolfram syndrome, DID-MOD, diabetes insipidus, diabetes mellitus, optic atrophy and sensory neural deafness. It is associated with the WFS1 gene mutation. Another neat question, prolactinoma. When you have got a prolactin level more than what concentration, you say that it is due to a prolactinoma. Okay, it is prolactin more than 500 microgram per liter, that we say that it is due to a prolactinoma. Okay, then what else? Okay, normal IGF-1. This is something that we have already discussed. If you have got a normal insulin-like growth factor 1, we can surely say that there is no acromegaly. Okay, that is used for the screening. This was asked in a previous question, asked as a previous question in AIMS. Then for confirming, you do the 75 gram OGTT. Normally, glucose is going to suppress GH. GH is going to become less than 1 nanogram per ml. Okay, but if that is not happening, we understand that there is acromegaly. Okay, then insulin like growth factor binding protein, this thing is also getting increased. This was another option in AIMS question, but this is not used for the screening. What was the screening? The screening method or screening test that we used, that was measuring insulin like growth factor 1. Then another option was is it possible to measure the growth hormone by one single random growth hormone test? No, it is not possible, because growth hormone is getting released in a pulsatile fashion. So no single random test is possible to diagnose growth hormone excess or acromegaly. Okay. Then another question was how do we classify it as micro adenoma and macro. Microadenoma is less than 10 millimeter. So you are going to check it with an MRI with contrast. In an MRI with contrast, it is going to come out very nicely. Microadenoma less than 10 millimeter, and pituitary macroadenoma, there is going to be, we know the features. No, we have already learned. Pan-hypopituitarism will be there, plus insulin sensitivity will be there. Why this insulin sensitivity is occurring in pituitary macroadenoma? We know that insulin is secreted from pancreas, no control from this pituitary. Insulin is secreted from pancreas, no control from the pituitary. That is how our thought goes. But this is actually negative regulation. Okay. When we have got pituitary macroadenoma, pan-hypopituitarism, cortisol is going to decrease now. When there is cortisol is going to decrease, there is positive effect on the adiponectin in the fat tissue. In our adipose tissue, there is something called as adiponectin that increases the insulin sensitivity. It was under negative control by the cortisol. But when this pan-hypopituitarism occurred, cortisol decreased, and therefore there will be adiponectin action predominantly, leading to increased insulin sensitivity. So that is pituitary macroadenoma. Now the discussion is not complete without talking about Craniofarijuma. It is a neat question. 2-3 times they have asked, I think. It is a benign supracellular cystic mass with calcification. Okay, you will see calcification on the MRI. You will see white spots on the supracellular area. In biopsy, you are going to give this characteristic motor oil-like fluid in a Craniofarijuma, and there will also be cholesterol crystals in Craniofarijuma. What is the treatment of choice that you use in Craniofarijuma? You either resect that thing, transcranial or transsphenoidal resection is done, then you give post-op radiation to prevent recurrence. There was an option in recent NEET that is surgery curative for Craniofarijuma? No, surgery is not curative for Craniofarijuma because it is adherent to the surrounding structures. Okay, so surgery is not curative, but that is what we do. We resect the mass and also give post-op radiation to prevent the recurrence. Okay. Then Craniofarijuma can be of two types. One is adamantinomatous and papillary. Okay. The difference between them is in adamantinomatous, the bigger one, there is going to be calcification present in the adamantinomatous type of Craniofarijuma, but in papillary the calcification is rare. That was another option in the recent NEET. Then headache is the most common presentation of Craniofarijuma. Okay, then we have got visual field defects involved with the pituitary mass. Superior quadrantopia, when you have got a prolactinoma more than 10 millimeter or macroadenoma, you are going to have superior quadrantopia. Initially, the ventral part of optic chiasma is getting involved. Therefore, we have got bitemporal superior field defect. Okay, bitemporal superior field defect, that is heteronymous. Then finally, when this mass enlarges, as the mass enlarges, it is going to compress much more and lead to a complete bitemporal hemianopia. Okay, so this is a heteronymous bitemporal superior field defect. So we think of what was this homonymous superior field defect, superior quadrant defect, that is seen in lesion of the optic radiation. Homonymous superior quadrant defect is seen in lesion of the optic radiation. And as promised, I am going to tell you how are we going to replace the pituitary hormones. Okay. Posterior post hypophysectomy, you are going to have panhypopituitarism. Okay, when there is ACTH deficit, you are going to give hydrocortisone and cortisone acetate, I think. Hydrocortisone and cortisone acetate. Why? You are not going to give the mineralocorticoid. It is just the glucocorticoid that you are replacing, because mineralocorticoid is not under the control of pituitary. It is under the control of RAS system. No problem. Then TSH. When there is a TSH deficiency, you are going to replace it with levothyroxine. Okay. Growth hormone, you are going to give it with somatotropin. That is how we replace. Vasopressin, you are going to give intranasal desmopressin, which is a ADH analog. Then FSH and LH, in males we are going to replace it with testosterone. In females, for fertility, menopause, if the that person has not attained menopause, you are going to give, for fertility, you are going to give menopausal gonadotropin. Menopausal gonadotropin and HCG are the two things that you are going to give for a premenopausal fertile female. For fertility, you are going to give menopausal gonadotropin and HCG. Postmenopausal female, estrogen and progesterone are the two things that you are going to supplement. Okay, so this finishes our 3-4 topics.